Welcome to this explainer. Today, we're taking a high-energy clinical deep dive into the raw power and, frankly, the fascinating physiology behind intravenous lasix, generically known as furosemide. We're going to unpack exactly how this potent loop diuretic functions and, more importantly, the profound impact it has on the human body. Because whether you're managing acute pulmonary edema or severe fluid overload, understanding the actual mechanics of this drug is absolutely essential.
To set the stage, ask yourself this: what actually happens to the body the exact moment lasix hits the bloodstream? We aren't talking about hours or even days here. We're talking about a massive cascade of physiological events that kick off in mere minutes. You see, the extreme speed of this medication is definitely its greatest asset, but, as we're going to see, it's also the source of its biggest clinical risks.
Here's our roadmap for today. Number 1, the power of IV lasix. Number 2, blocking the loop of Henle. Number 3, rapid hemodynamic shifts. Number 4, managing electrolyte imbalances. And finally, number 5, safe injection protocols.
All right, let's jump right into Section 1, the power of IV lasix.
When comparing the oral and intravenous routes, the difference is literally night and day. Oral furosemide has a wildly variable absorption. Thanks to inter-individual variability, its bioavailability hovers right around 50%. But honestly, it can range anywhere from 10 all the way to 100%. Plus, if a patient has heart failure, gut wall edema can delay absorption even further. That means it might take 30 to 60 minutes just to see an onset of action. But intravenous furosemide, it bypasses the gut entirely. You get 100% bioavailability, and the onset of diuresis begins within 5 minutes. In an emergency like acute pulmonary edema, that 5-minute window is the difference between struggling for breath and profound clinical relief.
Moving right along to Section 2, blocking the loop of Henle.
To truly understand how lasix functions, we have to meet its main target, which is the NKCC2 code transporter. This is a vital transport protein located specifically in the thick ascending limb of the loop of Henle. Normally, its entire job is to actively reabsorb sodium, potassium, and chloride from the urine back into the body. Well, furosemide is highly water-soluble at a normal physiological pH, so it gets delivered directly to the tubular lumen. Once there, it actually binds competitively to the chloride binding site of this exact protein. It essentially jams the pore, completely preventing the transport of these critical ions.
And this creates a wild physiologic domino effect. Step 1, as we just talked about, is the inhibition of the NKCC2 cotransporter. By trapping all that sodium and chloride in the tubular fluid instead of reabsorbing it, we trigger Step 2, disrupting the medullary osmotic gradient. Since solutes aren't moving into the medullary interstitium, its osmolality drops. That gradient, the one that usually pulls water back into the body, is completely impaired. And that leads right to Step 3. A massive increase in water excretion. The water simply has no osmotic reason to leave the collecting duct, so it's forcefully flushed out of the body as urine.
Now, to keep all these complex mechanisms straight, using a visual mnemonic is incredibly helpful. Also, keeping the chemistry in mind, furosemide is an anthranilic acid derivative that contains a sulfonamide group, making it technically a sulfa drug. This means it can absolutely cause allergic reactions in patients with a sulfa allergy. As you mentally visualize the drug working in the thick ascending limb, linking its mechanism of action directly to these potential side effects is a great way to keep the whole clinical picture in your head at once.
Let's zoom out a bit for Section 3, rapid hemodynamic shifts.
So before the urine even really starts flowing heavily, the cardiovascular system is already reacting to the drug. A rapid furosemide push causes immediate peripheral venous dilation. This shifts blood away from the cardiopulmonary circulation out to the periphery, causing the central blood volume to plummet by an astonishing 13% within just the first 5 minutes. Because of this massive, rapid fluid shift, cardiac output and stroke volume decrease. The body senses this sudden drop and immediately tries to compensate by jacking up total peripheral resistance. This is exactly why you'll often see transient increases in heart rate and mean arterial pressure, or MAP, in that first hour. It's a high-stakes hemodynamic roller coaster, and you've got to be ready for it.
Which brings us to Section 4, managing electrolyte imbalances. Real clinical study data reveals the exact toll this takes on a patient's vital electrolytes post-furosemide. Everything completely plummets. Sodium drops from 140.7 down to 136.5. Calcium and magnesium take significant hits too. But most importantly, look at the potassium falling from 4.5 down to 4.0. Because furosemide increases the delivery of sodium to the distal nephron, potassium removal via the urine escalates dramatically. This highlights the absolute critical risk of hypokalemia, which can lead to life-threatening cardiac arrhythmias if it isn't constantly monitored and supplemented.
Finally, let's wrap up with Section 5, Safe Injection Protocols.
Grounding our protocol directly in the FDA prescribing information, we can see the established guidelines. For an adult dealing with edema, the usual initial IV dose is 20 to 40 milligrams. But pay close attention to the administration instructions. It must be pushed slowly over 1 to 2 minutes. Even if you're dealing with acute pulmonary edema where the initial dose might be 40 milligrams, it still has to be injected slowly over that 1 to 2 minute window. The speed of the push is literally just as vital as the dosage itself.
So why is the speed so absolutely critical? Well, pushing IV lasix too fast can cause permanent deafness. Yeah, permanent hearing loss, a condition known as ototoxicity. And this risk skyrockets if you're using higher than recommended doses, if the patient has severe renal impairment, or if they're on concomitant therapy with aminoglycoside antibiotics. Now, we also have to watch for worsening renal function, specifically dehydration and azotemia, as well as keeping that sulfur hypersensitivity in mind. But ototoxicity? That's the immediate mechanical danger of a rapid push.
This brings us to our golden rule of thumb, the number 4. According to the clinical data, 4 milligrams per minute is the absolute maximum safe infusion rate for adults when using high-dose parenteral therapy. So, if you're ever setting up a continuous IV infusion, this is the critical threshold you absolutely must respect to protect your patient's hearing while still effectively managing their fluid overload.
Which brings us to a final thought. As we balance the urgent need for rapid, life-saving diuresis against the very real risks of profound hemodynamic and electrolyte crashes, how will you manage the 5-minute countdown the next time you push IV lasix? You now know the raw power of this drug, how it blocks the loop of Henle, shifts the body's hemodynamics, and drains vital electrolytes. Take this deep understanding into your clinical practice, always respect the speed limit of the injection, and stay one step ahead of the physiological domino effect. Thanks for joining me on this explainer, and keep learning.